Hyponatremia. Riveri, Robosa, Rodas, Rodriguez, Rogelio, Roque, Ruanto, Sabalvera, Salak, Salazar J, Salazar R, Salcedo. 51 years/O, female CC, vomiting. 1 week PTA. Fever, dysuria, urgency. Took paracetamol and antibiotic which relieved fever. 2 days PTA. Headache, body malaise, nausea, vomited 3x, 50 cc/episode. Admission. Persistence of symptoms. For smoking and alcohol history. RAS unremarkable. For smoking and alcohol history. Hypertensive for 10 years, taking telmisartan and HCTZ daily for the past month. Discontinued amlodipine due to bipedal edema. Weighed 50 kilograms but usual weight was 53 kilograms. P. Weak-looking and wheelchair-borne, poor-skinned turgor, dry mouth, tongue and axilla. BP supine 120/80. Sitting 90/60. Usual 130/80. HR supine 90 per minute. Sitting 105 per minute. Weighed 50 kilograms but usual weight was 53 kilograms. JVP less than 5 centimeters H20 at 45 degrees. Orthostatic hypotension, also known as postural hypotension, 1, orthostasis, and, colloquially, as head rush or a dizzy spell, and to some people the elevator effect, is a form of hypotension in which a person's blood pressure suddenly falls when the person stands up. The decrease is typically greater than 0.20 of a millimeter Hg, 2, and may be most pronounced after resting. The incidence increases with age. 3. Orthostatic hypotension is primarily caused by gravity-induced blood pooling in the lower extremities, which in turn compromises venous return, resulting in decreased cardiac output and subsequently lowering of arterial pressure. For example, if a person changes from a lying position to standing, he or she will lose about 700 milliliters of blood from the thorax. It can also be noted that there is a decreased systolic, contracting, blood pressure and a decreased diastolic, resting, blood pressure. The overall effect is an insufficient blood perfusion in the upper part of the body. Still, the blood pressure does not normally fall very much, because it immediately triggers a vasoconstriction, baroreceptor reflex, pressing the blood up into the body again. Therefore, a secondary factor that causes a greater than normal fall in blood pressure is often required. Such factors include hypovolemia, diseases, and medications. Orthostatic hypotension may be caused by hypovolemia, a decreased amount of blood in the body, resulting from bleeding, the excessive use of diuretics, vasodilators, or other types of drugs, dehydration, or prolonged bed rest. It also occurs in people with anemia. http://n.wikipedia.org/wiki/orthostatic_hypotension, RBC 2 to 5/HPF, not dysmorphic. Laboratory tests. HbE equals 132 mg/dl. HCT equals 0.35. WBC equals 12.5. Neutrophils equals 0.88. Lymphocytes equals 0.12. PNA equals 123 MEq/L. PK equals 3.7 MEq/L, N. CL equals 71 MEq/L. BUN equals 22 mg/dl. SCRE equals 0.9 mg/dl. Glucose equals 98 mg/dl. ABG. pH equals 7.3. CO2 equals 35. HCO3 equals 18. UNA equals 100 millimoles/L. Uosm equals 540 mosm/L. Urinalysis. Yellow, SL. Turbid. pH 6.0, Sg 1.020. Albumin and sugar, dash. Hyaline casts 5/HPF. Pus cells 10 to 15/HPF. RBC 2 to 5/HPF, not dysmorphic. Arterial values. pH 7.35 to 7.45. PaCO 235 to 45 mm Hg. HCO 322 to 26 meq/L. O2 saturation 96 to 100%. PaO 285 to 100 mm Hg. Urine. Color straw. Specific gravity 1.003 to 1.040. pH 4.6 to 8.0. Na 30 to 280 meq/L. K less than 8 meq/L. Cl less than 8 meq/L. Protein 1 to 15 mg/dl. Osmolality 450 to 900 mosm/L. Blood chem. Bun 6 to 23 mg/dl. Chloride 96 to 112 meq/L. Creatinine 0.6 to 1.5 mg/dl. Glucose 65 to 99 mg/dl. Potassium 3.5 to 5.5 meq/L. Sodium 135 to 148 meq/L. http://www.mt911.com/site/lab_anormal_lab_values.asp. Salient features: 51-year-old, female, vomiting, fever, dysuria, urgency. Headache, body malaise, nausea. Vomiting, 50 cc/episode. Known hypertensive. Telmisartan, 40 mg. Hydrochlorothiazide, 12.5 daily. Weak looking, wheelchair borne. BP, 120/80, supine, 90/60, sitting, 130/80, usual. HR, 90 per minute, supine, 105 per minute, sitting. Lost weight, poor skin, turgor, dry mouth, tongue and axillae. Normal JVP. What is the diagnosis? Hypoosmolar hyponatremia secondary to thiazide intake. Plasma osmolality equals 2 plasma, Na plus glucose/18 plus, urea/2.8. Equals to 123 plus 98 18 plus 22 halves 0.8. Equals 246 plus 5.44 plus 7.86. Equals 259.3 mosm/kg H2O, low. Normal plasma osmolality equals 275 to 290 mosm/kg H2O. Plasma Na plus concentration less than 135 meq/L, and is considered severe when the level is below 125 meq/L. Most causes of hyponatremia are associated with a low plasma osmolality. Hypotonic hyponatremia is due either to a primary water gain, secondary Na loss, or a primary Na loss, and secondary water gain. Contraction of the ECF volume stimulates thirst and AVP secretion. The increased water ingestion and impaired renal excretion result in hyponatremia. http://emedicine.medscape.com/article/242166 overview. http://www.benhuck.com/post/1816/ Basis. Signs of ECF volume contraction. Body malaise. weakness, poor skin turgor, dry mouth and tongue, dry axillae, postural hypotension, postural tachycardia. Clinical features. Patients may be asymptomatic or complain of nausea and malaise. As the plasmin A+ concentration falls, the symptoms progress to include headache, lethargy, confusion, and obtundation. Stupor, seizures, and coma do not usually occur unless the plasmin A+ concentration falls acutely below 120 mmol/L or decreases rapidly. The clinical manifestations of hyponatremia are related to osmotic water shift leading to increased high CF volume, specifically cerebral edema. Sodium 125 nausea and malaise, 120 headache, lethargy, obtundation, 115 seizure, coma. A careful history is often helpful in determining the etiology of ECF volume contraction, for example, vomiting, diarrhea, polyuria, diaphoresis. Most symptoms are nonspecific and secondary to electrolyte imbalances and tissue hypoperfusion and include fatigue, weakness, muscle cramps, thirst, and postural dizziness. More severe degrees of volume contraction can lead to end organ ischemia manifest as oliguria, cyanosis, abdominal and chest pain, and confusion or obtundation. Diminished skin turgor and dry oral mucous membranes are poor markers of decreased interstitial fluid. Signs of intravascular volume contraction include decreased jugular venous pressure, postural hypotension, and postural tachycardia. Larger and more acute fluid losses lead to hypovolemic shock, manifest as hypotension, tachycardia, peripheral vasoconstriction, and hypoperfusion, cyanosis, cold and clammy extremities, oliguria, and altered mental status. http://www.benhock.com/post/1816/ Factors that contributed to the development of hyponatremia in the patient. Vomited 3x, 50 cc/episode. Primary sodium loss, secondary water gain, gastrointestinal losses. Due to vomiting predisposes the patient to hyponatremia since there is a corresponding sodium loss associated with water loss. Intake of hydrochlorothiazide. Primary sodium loss, secondary water gain, renal losses. It is important to note that diuretic-induced hyponatremia is almost always due to thiazide. Diuretics lead to Na+ and K+ depletion and AVP-mediated water retention. Inhibits reabsorption of sodium and chloride in the distal convoluted tubule, promoting water loss. Intake of telmisartan ARB. Inhibits tubular Na and Cl reabsorption, K excretion, water retention, promotes water loss, computation of the plasma osmolality and the effective plasma osmolality. Osmolality, calc, equals 2x Na plus glucose plus urea if all measurements in mol/L. Osmolality, calc, equals 2x Na plus glucose/18 plus urea/2.8 if measurements are in mg/dl given. Plasma Na equals 123 meq/L, glucose equals 98 mg/dl, urea equals 22 mg/dl, osmolality equals 123 plus 98 18 plus 22 halves 0.8, osmolality equals 259. 301. N equals 275 to 295 milliosmoles per kilogram. Becker, K. 2001 Principles and Practice of Endocrinology and Metabolism, 3rd ed. Effective osmolality, calc, equals 2x Na plus glucose. Effective osmolality, calc, equals 2x Na plus glucose if all measurements in mol/L. Osmolality, calc, equals 2x Na plus glucose/18 if measurements are in mg/dl given. Plasma Na equals 123 MEq/L. Glucose equals 98 mg/dl. Urea equals 22 mg/dl. Osmolality equals to 123 plus 98 18. Osmolality equals 251.44. Less than 275 equals hyponatremia. Becker, K. 2001 Principles and Practice of Endocrinology and Metabolism 3rd ed. Importance of computing for the plasma osmolality and the effective plasma osmolality. ECF tonicity is determined primarily by the Na plus concentration, and patients who have hyponatremia have a decreased plasma osmolality. Becker, K. 2001 Principles and Practice of Endocrinology and Metabolism 3rd ed. Significance of urine osmolality, UOSM. A more exact measurement of urine concentration than specific gravity. Patient with UOSM below 100 mOSM/kg are able to appropriately suppress ADH release, leading to a maximally dilute urine. Patients with a higher urine osmolality have an impairment in water excretion due to the presence of ADH. Indicated to evaluate the concentrating and diluting ability of the kidney. Accurate test for decreased kidney function. Monitor course of renal disease/electrolyte therapy. Renkh, Denker, B. 2007. Renal Pathophysiology, The Essentials, Significance of Urine Sodium, UNA. Helps distinguish renal from non-renal causes of hyponatremia. Urine sodium exceeding 20 MEq/L is consistent with renal salt wasting. Diuretics, ACE inhibitors, mineralocorticoid deficiency, salt-losing nephropathy. Urine sodium less than 10 MEq/L implies avid sodium retention by the kidney. Compensation for extrarenal fluid loss, vomiting, diarrhea, sweating or third space wasting. Renkh, Denker, B. 2007. Renal Pathophysiology, The Essentials, Effective Circulating Volume Depletion and SOD are the two major causes of true hyponatremia, with an inappropriately high urine osmolality, and these disorders can be distinguished by measuring the UNA. Patients with hypovolemia are sodium avid in an attempt to limit further losses. Urine sodium is generally below 25 MEq/L. In comparison, patients with SOD are normovolemic and sodium excretion is in a steady state equal to intake. Urine sodium concentration is typically above 40 MEq/L. Renkh, Denker, B. 2007. Renal Pathophysiology, The Essentials. Computation of Na deficit. Sodium deficit equals total body water normal weight in kg, PTS Na, desired Na. TBW equals 0.6 if male and 0.5 if female. Computation of Na deficit. Sodium deficit equals 0.553 kilograms, 135 MEq/L 123 MEq/L. Sodium deficit equals 318 millimoles/L. Principles of therapy. Raise plasma sodium concentration by restricting water intake and promoting water loss. Correct underlying disorder. Principles of therapy. Asymptomatic hyponatremia. Sodium repletion, isotonic saline. Restoration of euvolemia removes the hemodynamic stimulus for AVP release. Restriction of sodium and water intake, correction of hypokalemia, and promotion of water loss in excess of sodium. Dietary water restriction should be less than urine output. Principles of therapy. Asymptomatic hyponatremia. Sodium concentration should be raised by no more than 0.5 to 1.0 millimoles/L over the first 24 hours. Acute or severe hyponatremia. Plasma sodium conc, less than 110 to 115 millimoles/L. Rapid correction. Severe symptomatic. Hypertonic saline. 1 to 2 millimoles/L per hour for the first 3 to 4 hours. Raised by no more than 12 millimoles/L during the first 24 hours. Complication of rapid correction of hyponatremia. Rate of correction depends on the absence or presence of neurologic dysfunction. Related to the rapidity of onset and magnitude of fall in plasmin A+ concentration. Rapid correction of hyponatremia leads to osmotic demyelination syndrome, ODS. Fauci et al. Harrison's Principles of Internal Medicine, 17th ed. Osmotic demyelination syndrome. Neurologic disorder characterized by flaccid paralysis, dysarthria and dysphagia. Mechanism. Patients with chronic hyponatremia. Brain cell volume has returned to near normal. Malnutrition secondary to alcoholism. Prior cerebral anoxic injury. Hypokalemia. Administration of hypertonic saline. Sudden osmotic shrinkage of brain cells. Fauci et al. Harrison's Principles of Internal Medicine, 17th ed. Velaectomy and hyponatremia. 2009. http://emedicine.medscape.com/article/907841 Central ponton myelinolysis. Subtype of osmotic demyelination syndrome occurring in the pons. Occurs when hypertonic saline is given too rapidly in a patient in whom hyponatremia has been present for greater than 24 to 48 hours. Potentially fatal neurologic syndrome characterized by quadriparesis, ataxia, abnormal extraocular movements. May result in brain damage and death. Schwartz's Principles of Surgery, 8th ed. Fauci et al. Harrison's Principles of Internal Medicine, 17th ed. Velaectomy and hyponatremia. 2009. http://emedicine.medscape.com/article/907841 Follow-up. Central ponton myelinolysis. Predilection for pons. During hyponatremia, these cells can adapt only by losing ions instead of swelling. This limitation makes them prone to damage when Na is replaced. Grid arrangement of the oligodendrocytes in the base of pons limits their mechanical flexibility, thus capacity to swell. The predilection for myelinolysis in the pons is thought to be a result of the grid arrangement of the oligodendrocytes in the base of pons, which limits their mechanical flexibility and, therefore, their capacity to swell. During hyponatremia, these cells can adapt only by losing ions instead of swelling. This limitation makes them prone to damage when Na is replaced. Velaectomy and hyponatremia. 2009. http://emedicine.medscape.com/article/907841 Follow-up. Central ponton myelinolysis, MRI flare. D2 weighted magnetic resonance scan image showing bilaterally symmetrical hyperintensities in caudate nucleus, small, thin arrow, putamen, long arrow, with sparing of globus pallidus, broad arrow, suggestive of extraponton myelinolysis. Intravenous fluid to use and rate of infusion. 3% saline infused at a rate of less than or equal to 0.05 ml/kg body weight per minute. Effect should be monitored continuously by stat measurements of serum sodium at least once every 2 hours. Fauci et al. Harrison's Principles of Internal Medicine, 17th ed. Intravenous fluid to use and rate of infusion. Infusion should be stopped as soon as serum sodium increases by 12 millimoles/L or to 130 millimoles/L, whichever comes first. Urine output should be monitored continuously. SIAD can remit spontaneously at any time, resulting in an acute water diuresis that greatly accelerates the rate of rise in serum sodium produced by fluid restriction and 3% saline. Fauci et al. Harrison's Principles of Internal Medicine, 17th ed. Most cases of hyponatremia can be treated by free water restriction and, if severe, the administration of sodium. In patients with normal renal function, symptomatic hyponatremia does not occur until the serum sodium level is greater than or equal to 120 MEq/L. If neurologic symptoms are present, then 3% normal saline should be used to increase the sodium by no more than 1 MEq/L per hour until the serum sodium level reaches 130 MEq/L or neurologic symptoms are improved. Correction of asymptomatic hyponatremia should increase the sodium level by no more than 0.5 MEq/L to a maximum increase of 12 MEq/L per day, and even slower in chronic hyponatremia. The rapid correction of hyponatremia can lead to pontin myelinolysis, 42 with seizures, weakness/paresis, akinetic movements, and unresponsiveness, and may result in permanent brain damage and death. Magnetic resonance imaging, MRI, may assist in the diagnosis. 43.